right, so let's get started. So today we will be presenting a webinar brought to you by the National Center for Health in Public Housing on screening for violence risk in people living with disabilities, a practical approach. My apologies, but we have a typo here. And this presentation is going to be led by Dr. Kevin Michael Lombardi, who is the Director of Research at the National Center for Health in Public Housing.
Yes, also the director of typos. So let's see how many more we find today. Onward. I will say briefly though, this is a very difficult subject to talk about. Let me tell you, going into the literature review and updating myself and my colleagues on the disparity with this population and their experience with regards to violence was eye-awakening and certainly reoriented my focus. And I hope to share that with all of you today. And for those of you who are experts in this field, which I've never had a webinar where it hasn't been full of them, I really do want to hear what you're doing, how you're seeing your patients, what's working, and how that feels. So next slide, please.
All right. Thank you, Dr. Kevin Lombardi. And then also, there's somebody mentioned that there is an echo. I'm not sure. I'm not hearing it from my end, but hopefully that is just like a technical issue that maybe it could be fixed on the computer.
Yeah, I'm not hearing one either.
Yeah.
That may be a individual device issue. I recommend playing with your mute, and that's all I know how to do here. That's the extent of my technical knowledge.
All right, so let's get started now. This is just a few housekeeping items that I'd like to remind everyone about. Just remember that all participants are muted upon entry. Please make sure that you engage in the chat and raise your hand if you would like your line to be unmuted. So throughout today's webinar, we encourage that you participate, that you engage also through some of the activities that we will be having. Particularly, we're going to have an example of a case study in which Dr. Lombardi is going to be going over. So we encourage you to provide some input during that section. Also, the meeting is being recorded. The slides and the recording link will be sent to you via email after today's session. And here's just some information about the National Center for Health in Public Housing. So NCHPH is supported by the Health Resources and Services Administration and is a national training and clinical assistance partner. The information or content presented today are those of the author only. The mission of NCHPH is to strengthen the capacity of federally qualified, federally funded public housing primary care health centers and other health center grantees by providing training and a range of technical assistance. All right, so just a brief introduction about myself. My name is Fide Sandoval, and I am the TTA manager here at NCHPH. I will be helping with the moderation of today's session and also with helping with the engagements as well. And if you also have any questions regarding the webinar or any follow-up items, you can always contact me at fide.pineda@mgt.com. And we also have Dr. Kevin Lombardi. Would you like to provide a brief introduction by yourself?
I would love to. Dr. Kevin Lombardi, physician, epidemiologist, training in internal medicine, epidemiological focus on interventional and preventative epidemiology. I use data to talk about folks that are absent, missing, or underrepresented in data and inform policy. I'm also a member of the board of director of MHP Salud, which is a CHW and Latino health-focused healthcare organization. And I lead the health portion of the 10-year panel on public housing. So I see this issue from the clinical to policy stance, and I'd like to share as much of that perspective as I can as it pertains to your clinical work and your professional success.
All right, thank you so much, Dr. Lombardi. All right, and then here we have just some background information about those public housing primary care health centers and public housing developments. So according to 2023 UDS data, there were over 1,300 FQHCs that served to 31 million patients. 475 FQHCs were near public housing that served to 6.5 million patients. And 107 PHPCs served to over 900,000 patients in 2023. And here is just some PHPC Health Center patient demographics data. This is according to UDS as well. So in 2023, 77.36% reported to be below the federal poverty level. 58.15% were female, 29.96% were children, over 10% elderly, and close to 19% were uninsured. And then here we have public housing residents demographics data. So this data was obtained by the HUD picture of subsidized adults. And you can see here that back in 2023, there were 1.6 million residents with 2 persons per household. 32% were female-headed with children households, 35% were children, 40% elderly, 90% were of very low income, and also a very important demographic to mention here is the 23% that were disabled amongst all persons in households. And in terms of race and ethnicity, 42% were Black, non-Hispanic, 29% white, non-Hispanic, and 26% Hispanic. All right, and then here we have just a quick overview about today's learning objectives. Dr. Kevin Lombardi, would you like to?
You can head through these. We're gonna get right into it.
Okay.
But what I like to call this is the micro to macro view. From the patient to the public health perspective is much like looking at like a chemical compound or a biological compound. You have from the macro, the clinical effects down to the chemical structure. So let's try to look a little bit at a process here. So this is my system based on an understanding of the literature of adult learning and how high-functioning professionals like yourself use TTA. So we are going to do a literature review, look at some of the details of the data and what it tells us, how it informs clinical practice. We'll look at some epidemiological data as well that highlights and focus us towards areas where we should be emphasizing our attention clinically. We'll break those findings and recommendations down, talk about how those impact our workflow and so forth, and some more stuff. I have a clinical case study in here that is quite extensive, and frankly, we could spend an hour just doing that. These slides are not designed to be taught from only. They are designed to be consulting documents. They're made in the same format if you paid a consultant that they would give you. The documents are interactive. The data is there, links to the papers are there. So I really encourage you, for those of you who want to take the most you can from this, one, make sure you have espresso, which is always necessary when looking through methodology, but also discuss it with your colleagues, bring things up in meetings. This is how we impart structural change and improve our organizations. So next slide, please. More on the system. Next slide. Okay, well, let's just get right into it here, Fide. Malhot et al. So when I do my literature reviews, I like to see if there's a new meta-analysis that can inform my practice. And this one I really liked. I looked at the methodology. It's very solid, a lot of studies. And it gave me some numerical information that helped direct my attention. Fide, looking at that slide, can you pick that up? And if not, tell me. What numerical information in these paragraphs do you think diverted my attention?
Oh, for sure. Definitely just looking at the significant levels for the higher risk of sexual victimization among individuals with any disability.
Yeah, it was those odd ratios, though, specifically.
Yes, exactly.
So let's talk about odd ratios because they throw them around in papers a lot, and we talk about them a lot when we're having intergroup meetings, we're having interdisciplinary meetings. Odd ratio takes a standardized population, say it's usually the U.S. general population or person or people without a disease, and it gets their risk of something. We do very simple math, just a logistic regression to give us for a subgroup what their increased risk is. So odd ratio of 2.27 means that individuals with disability are 2.27 times more likely to experience sexual victimization. And that got me because that's also 270%. It's two ways of saying the same thing. And that disparity is significant. And when I think of the impact that has on individuals' lives and how it impacts clinical practice, the first thing I thought to myself is, I am not giving enough attention to this. I don't know what this data did to you, but from myself in the primary care setting, when I read information like this, it diverts my focus. So also worth noting and reading that the risk of sexual victimization among individuals with disabilities were much higher in adults, 2.84 than in children, 1.40. That was a surprise to me. I checked the methodology, and the math is correct. And I guess the assumption I would always make that is made was that adults were not at that high a risk. So, and that's what meta-analyses and literature like this does for us. It helps us focus and see more clearly the public health realities that we swim in, the ecosystems we live in. Next slide, please. And FYI, Fide, I'm not the greatest multitasker, so if you do see comments that are worth stopping me, please do.
Yeah, for sure. We did receive a comment by Quentin, and I just replied in the chat, and they said pretty decent number of participants too. That's always good to note. It's not like they're making inferences based on a study that only included 15 people.
And you know, Quentin, that's the thing that gets my attention, right? And we all know this pyramid of evidence that they teach us about. I start at the top there because these good and meta-analyses only come out every couple of years. But if you do a good solid literature review and you do even a Google Scholar search for a topic and meta-analysis, you can find some really high quality stuff. So, and the other thing is we are talking about clinical intervention here. These aren't drug trials, I know, but we're talking about how we interact with vulnerable individuals in a clinical setting. There is nothing more serious. You only tie with that. So making sure the evidence we use is at the very top of the pyramid isn't just a good thing. It's a clinical responsibility. So I'm psyched that everyone agrees with me on that. Next slide, please. Okay, so the other thing they did is went over a lot of promising practices, what could be translated into promising practices. So what I did is I went over the data and you looked at the conclusions they made, and I sort of translated them to our industry. So let's talk about them. Fide, here I go. So one, healthcare professionals should receive training to assess for sexual victimization of person with disabilities. Okay, let's break down that system and plug that into a practice recommendation. What I would say is appropriate for those of you who are in the primary care setting is to integrate this into your HR practices. Your individuals, when they work for your health center, will receive standardized education that's designed by HR. They should be learning about priority populations in those educational formats, whatever they are, in person or remote, and making sure they know about your screening protocols is very important.
Yeah.
If you're at
Sorry, Dr. Lombardi, just wanted to interrupt real quick since we're really talking about practice recommendations here. I guess we'd be curious to also learn about it. Maybe the audience can provide this in the chat or even raise your hand. What are some of your own practice recommendations that you would like to share with the audience today? Could be from your organization or from your health center. So just something to keep in mind.
Let me just take the ball for a second and say, especially I want to hear about screening. Where are you guys doing it? Mm-hmm. So I'll sip my espresso for a second and wait.
Yeah, so more than welcome to provide your input right now, and we can just maybe give a few minutes as well.
So I'll keep yapping, Fide.
Yeah.
Time is of the essence. Please put something in the chat as I keep going, and we want to pull you into the conversation. And we're delightful in conversation. We received training for it. Yeah, we used to be a little rough around the edges, but then Fide fixed that. Okay, so ensure physical and adapted access to support services. You know your partner list. Do you know that your partner lists, do you know what their accessibilities to their buildings are? You would be surprised how many facilities that are specifically designed for this population, individuals with disabilities, do not have appropriate access. That communicates something to people. Show people with individuals that they are priorities by making sure access is good, it's clean, and it's up to date. So everyone should take a look at that at least once a year, and it's something that your board of directors should be knowing about. And if they're not asking about them, send them a text message that they should. And I will say broadly, for those of you who are in the management position or are speaking with either executive management or your board of directors, your guidance on what the priority populations is very important to communicate to your board of directors, because they're going to be the ones signing off on programs, and they're going to be the one that's speaking to your executive director every day. I always encourage organizations to de-siloize through communication systems in their organization. You know, Fide, one of the organizations that I serve on the board of, a healthcare organization, they recently used their grant system to make better communications amongst their whole organization. What they did is they had a grant system that required all the program heads to look at things and attend a meeting twice a month. They had to meet something on the schedule, and they looked at things, and that put them in the same room, and they started having conversations.
Wow.
Is it time to interrupt me?
Yeah, and speaking of that, we did receive input by Quentin. They said we screen for victimization with all patients in the same screening section of the primary care appointment as SDOH, smoking, depression, and anxiety. And I'd be curious to know where or what organization you're joining us from as well.
Quentin, could you join the conversation?
Yeah. All right, so I'm going to unmute the line.
Good afternoon. How are you?
Good afternoon. Doing great. Thank you for joining.
Thanks for having this conversation. You asked about my organization. I work at a federally qualified health center in Rhode Island called East Bay Community Action Program.
Mhm. Oh, nice. Okay.
So you mentioned a couple of things. You mentioned the framework that you guys are using in primary care. And I'd love to hear it from the horse's mouth, because I think you guys nailed it.
Not quite the horse's mouth because I'm admin and not clinical. But
So the guy that knows the horse, though, that's good enough for me.
absolutely, yeah. So we do a lot of screenings. As a federally qualified health center and a community mental health center, we have integrated behavioral health and primary care services. So we do a whole bunch of different screenings for victimization, for social determinants of health, smoking cessation, depression, anxiety. We use the Prepare. We have community health workers that we can connect folks to. Being a very large organization, we try and fill as many gaps as humanly possible, and that means we have lots and lots and lots of internal programs that we can refer folks to when we find a need based on these screenings.
You know, I gotta say, I've got a weekly meeting with CDC and HUD, and I just got off a task force meeting for public housing primary care. And I've got to say that when I hear things like this, like that is the most data-driven sentence I've heard all year. What a fabulous programmer way you guys have, and congratulations. Like, that's amazing.
Thank you so much.
That level of program oversight, that requires managerial jujitsu to do. So good for you, and for the service to your community.
Thank you so much.
I do have a follow-up for you, though.
Oh,
So
sure.
you're talking about an infrastructure for individuals with disability, just to make it as simple as possible. Now, I'm wondering, for that individual with disability who comes to your health center, do these programs have any effect on them psychologically, behaviorally, coming into a place that's clearly prioritizing and communicating a prioritization of their needs?
From what I've seen, I think it does have a pretty significant positive impact. The one thing to clarify, though, is that we do this for all of our patients. Today's conversation is focusing on those with disabilities, but that's a very, very tiny proportion of our patient group. And so these screenings are provided to every single patient. We make sure that all of our information is verbally and written, provided in a way that makes sense for the patient, whether that be their primary language that they speak at home, or making sure that it's written at a relatively low reading level so that everybody can access it, providing case management and all sorts of supportive interventions for any patient that needs it. It definitely does have a positive impact on our patients with disabilities, but like I said, it's for everyone.
You know, I want to poke a little bit more, and please tell me when I get you out of breath.
Yeah.
But you know, something Fide and I have been engaging a lot with is the migrant population, and this is a population that disproportionately experiences a variety of disabilities.
Mhm.
And I guess Fide, I'm going to ask you to grab the football and then toss it to Quentin. I'm thinking about general frameworks where we happen to have someone who manages a very well managed network, and I'm thinking about migration, and I'm thinking about your patients, and if you've experienced more patients from outside of the country, and if you had any thoughts on how your systems have allowed you to serve them.
Yeah, great question. So we provide services to folks who are documented or not. We provide folks services whether or not they have insurance. We have sliding scale options for folks for payment, which definitely helps. But the physical location that I'm in, we don't have a very large pool of migrant patients. It definitely has increased ever so slightly over the last couple of years, but it's not a very commonly served population for my organization. A couple of our sister health centers over in the northern and western parts of the state definitely have seen an increase over the last probably 3 to 5 years.
So thank you so much first for your very proud to call you a colleague, Quentin, and thank you for your service. I'm going to stay on migration for just one more second, because you know we've got so many different waves of individuals that have come through this country historically, and if you look at all the maps of where people have gone, how they have moved over the different waves of immigrations we've had. What it tells me is that every community should have a system that's ready to take large volumes of migrants, because we just don't know when the migration patterns are going to shift and those individuals are going to need healthcare and be at our doorstep. So I love hearing from health centers that are so responsibly prepared for their communities. And I'm going to say maybe next slide, because I'm famously not conscious of this when I get going. So let's talk about epidemiology. I'm an epidemiologist, and it's my favorite word to say. Epidemiology is a perspective. Um, and when I look at maps, when I look at percentages, and when I look at graphs, I see that in the same way as a physician when I look at a potassium, or I look at a calcium, or an A1C. They're indicators. And what these indicators tell me, just like in a clinical sense with a chemical indicator, is where to divert my focus. So let's look at some indicators. So, and these papers are all cited, and if you're interested in this topic and you want to look at the data and the methodology, it really does tell you a lot, and is a great companion for a morning coffee. Fide knows. That's what she makes me do. So anyway, so let's look at this bit by bit. Increased risk of sexual victimization, individuals with disability. Their rate is 270%, or 2.7 times the general US population. That's individuals that do not identify as having any disability. Increase of rape, women with disability. This one was very difficult to read. 3.3 times the general population. This is people's lives. And here's another one: increased lifetime risk of non-consensual sex, men with disabilities. We often forget that this disparity is experienced by all genders, 1.5 times the general population. You know, I've worked with individuals with disability who have this history before, and I can't put words to the human experience that is behind these numbers. What I can do is divert my focus clinically to making sure I'm taking screening seriously and make sure I'm listening to my patients with disability. Also, something I take very seriously that I think I'm not alone in saying is I'm a mandated reporter, and that's a social responsibility that has been given to me and one that I take very seriously. When I have a question in my mind, if abuse is happening, I call adult protective services, I call child protective services, and I don't feel bad doing it because that's a instruction I have been given by society to do that. And to be frank, I've done it enough to know that the outcome is always good. So if you suspect abuse, if you are seeing bruises that are uncharacteristic or strange, pull the trigger. The individuals that will look into that are professionals. I've seen them do their work. They take it very seriously. They take it very gently. And they take your relationship and maintaining your relationship with the patient very seriously as well. I can say at times when I had trepidation in using my mandated reporter responsibility, it's because I was worried about that relationship with the patient or disturbing a social situation which I saw as unstable. I no longer see it that way because I've had the experience of seeing what actually happens. And I would tell those of you who are mandated reporters, have discussions about these responsibilities with your colleagues and leverage their clinical experience. So that's what I have for you on this one. Next slide when you're ready, Fide.
Thank you, Dr. Lombardi. Actually, even like for me, like from my own perspective, I'm currently pursuing my MPH in epidemiology, and just seeing these numbers as well, like it's very alarming. Just to see like the impact and how big of an issue this is, you know, to see like all of these increased risks among patients with disabilities. So
Yeah, you know, when I see these numbers, and here's some more. Here just to get the point across. I guess to myself and to everyone else. Here's the lifetime risk of non-partner physical violence for both men and women. And what I'd like to focus on here is the lifetime rate non-partner physical violence of men with disabilities. Over half of them. That's extremely alarming. I think I called you when I read this.
yes, we
And
had a very long discussion.
like Fide, I had no
Had
idea.
to share this
I
with
had
the
no
audience.
idea and you think of what people experience. First of all, an individual with a disability, and then they have this trauma of physical violence, that's going to affect how they operate in their physical space around other human beings, possibly for the rest of their lives if it's not addressed clinically. So these are individuals that we need to screen for, but also we need to provide comprehensive support for. Because this rate tells you a lot about how much you're missing it if you're not asking. And also lifetime rate of non-partner sexual violence, disturbingly high as well. These are patients that deserve our attention. And when you see rates like this, it's alarming. Yes. But let me just try to impart a positive perspective on it. You didn't make these numbers, neither did I. We're here trying to fix things. And when I see this, I see low-hanging fruit because I know every time I catch this when I wasn't, there's a 50-50 chance that I'm going to get something and I'm going to make a difference in someone's life. And when you're going in exam room after exam room and you need something to lift yourself up, let me tell you, that's like a cup of coffee. It goes best with an actual one too, though, I will say. Next slide, please. Okay, let's see the time here. Oh, we're going into this. What do you say, Fide? Can I go full case study?
Yes, I think we have enough time.
Anything in the comments I need to address before we get into this?
Nope, not right now.
Okay, Case studies is how you learn medicine, folks. And it's how I learned medicine. It's how I communicate with people. Sometimes I'll just call Fide like after work and I'll make her do a case study with me. She loves that. That's great. It's like the cup of wine at the end of the day because it puts things together. It puts epidemiological information, physical information, and it imparts an understanding of our colleagues. So here's what I did. I made a case study that's patterned in a way that I would have been taught, and I pieced it apart to so we can delve into individual pieces of primary care and patient care that matter for this. And for those that who are not clinical, what I'd like to garner is one, an understanding of what your colleagues deal with, and two, your perspective of how that pertains to your work. Because we're all building brick walls together here, one on top of the next. And I find, having been in the clinical and managerial seats and playing musical chairs with them sometimes on a daily basis, they definitely inform each other. Definitely inform each other. And what that means at the end of the day is an easier day and you're getting your work done better and quicker. So let's talk about Mr. Tarzia. Okay. Mr. Tarzia was diagnosed with congestive heart failure in 2017. Very debilitating disease if poorly controlled. The results of 30 years of poorly controlled hypertension complicated by cigarette smoking. 2, Mr. Tarzia began to experience bouts of acute pulmonary edema, backup of essentially interstitial fluid into the lungs. Feels like you're drowning, very uncomfortable. In 2018, and was diagnosed with chronic pulmonary edema in January 2019. Mr. Tarzia went on Social Security disability in May 2019 and started struggling with depression in June 2019. He was diagnosed with major depressive disorder. After his diagnosis with CHF, Mr. Tarzia began to experience kidney damage as well. Now, these things follow. This patient I've seen 100 times, sometimes way more than 100 times. This is a very common disease progression, and it's because that's how our body works. When you have uncontrolled hypertension, it just takes that. It just takes that to get the ball rolling and interacting with other disease states to push you towards disability. And that just reminds you to thank our primary care superheroes because they're the ones trying to pull apart this ball of yarn. So thank you for your service. Anyway, we've got kidney damage, and he's diagnosed with CKD3 in 2020 and CKD4 in 2021. From bad to worse, due to recent years of cigarette smoking, he's also got urothelial carcinoma. So this might seem like a lot, but this is an exceptionally common patient. And if you're in a health center, you see him every day. You see him every day. Next, so we got 1, congestive heart failure. 2, pulmonary edema as a result. 3, we've got a diagnosis of depression. It's not there for an accident. The data tells us that 30 to 40% of these individuals have are experiencing a new diagnosis within 12 months of the onset of their disability. Then we have chronic kidney disease, further complicating the disability. You think chronic kidney disease is just numbers until you see enough people living with it. Chronic kidney disease slows you down. Your electrolyte balance is much more difficult to balance when you've got only 20% of your kidney function. That results in exhaustion. Now, if you're already physically disabled because of something else, now you've got to deal with the added exhaustion. What it does is just takes options away from you. And that is extremely limiting. And I don't know if you've ever been limited before, but it certainly makes me depressed. So just a perspective. Next slide, please. Okay, so we got the timeline here. This is, use these slides with your friends, maybe at a interdisciplinary meeting. If you like talking about case studies, I find they're a good framework for discussion because you can just bring in all sorts of things when you're talking about patient care. Think of it as a poetry. So we got the heart. We did this. Next slide, please. I got excited when I was doing this one. So we can do the next slide, Fide.
Yes. Sorry, my computer is acting up a little bit.
Are you
Forgive
frozen?
me. Yeah, a little bit. So
I thought
hopefully
you
it
were
will
just
be
holding
working.
really still.
Yeah. I'm
Up.
so sorry to the audience, but sometimes we do have these technical difficulties.
This every time. I'm starting to think it's on purpose. I'm just teasing, Fide. You know me.
Okay. How
Okay,
about now with the arrow? Case study. Yeah, there you
are
go.
you back?
So we can see
Back a
like the
bit?
cycle.
Oh yeah, here we go. Okay. All right. Part of the show, folks. So here it is. So these things are all working together and conspiring to make Mr. Tarzia's experience every day more limiting, more frustrating to him, and making it so that he needs, excuse me, to rely more on things he had not relied on. Now, when I think of this patient and I think of them in primary care, this is a great individual to work with a CHW and a coaching-based model, which I know many of you guys use. This is someone who would love to know what options are available for them. And what does that feel like to them? It feels empowering. If you have a medical condition that's taking options away from you, but your CHW is giving you options, what that feels like is more independence. And what it does is it empowers people to take more control of their life. Well, let me tell you, I've worked a lot with a lot of people with chronic diseases, and when they have that attitude, it's a lot easier to walk them towards the hard decisions that they need to make to maximize their health. So, power to you. Next slide, please. Yeah, I was excited about this one. Next slide. Okay, so what does this lead to when we have a patient like Mr. Tarzia who's dealing with a lot? He's dealing with a chemical assault every day, really. So one, poor subjective experience. We can wrap that under the MDD as well. That's his individual experience as a human being. And that's as self-reported. Plus, increased infection risk for a variety of reasons. This comes from sores. This comes from lack of exercise. This comes from increased stress. It comes from poor diet that often has as a result of immobility. That comes as the result of an individual losing options to be able to take care of themselves. So emotional well-being as well. Increased risk of social isolation. Of course, individuals are less able to go out and interact. And interacting with people is just, it's the life and soul of who we are as humans. So we want our individuals with disability to be able to be their full selves. And that means getting out there and doing what they want to do. I got to tell you, Fide, there's some family members in my family that have disability, and my aunt is a gardener, and she can't bend down anymore. And we raised her garden beds so that she can have her little tomato plants. And I can't tell you why exactly her health is better since we did that, but I know when people do what they love, they're healthier and they're happier. So I lost the slides, Fide. Did we lose Fide?
I think you lost Fide.
Oh no. Okay, well luckily I got him right here. All right, problem solved. Okay, so we have our timeline, our patient outcomes, and when I think of this, and I'm trying to sort of give insight into a mental map that formed when I was reading this. When I think of all these patient outcomes that this individual is at higher risk for, Hey, Fide. I took it, then you took it back. Could you put the slides
Yes.
up when you get a sec?
Yeah. My apologies. Something happened here with my Zoom. It just stopped working. So
It's
can
because
you
you
see?
gossip about it behind its back. That's why. Next slide, please.
Okay. Can you see the screen? Which screen do you see? The one with the slides?
Case study patient outcomes. I want you to go one forward, please.
Great. Thank you.
Okay, so what do all these do? When you think of all of these different risks that the patient experiences, and there's many more than I had listed, what these translate to are physical and social disempowerment and increased risk of experiencing violence, both physically and sexually.
Mhm.
Next slide. And if you want to think of this on a population level, in your health center, you've got all these different Mr. Tarzias and Mr. Tarzia adjacent folks. What that leads to is these public outcomes being present and predictable, meaning that you can address them programmatically.
Mhm.
That's another webinar. Next slide, please.
Okay.
And let's see how we're doing for time. Okay, so we're going to talk about SDOH and supporting these individuals with SDOH services. Next slide, please. Okay, so let's think of Mr. Tarzia. Okay, so we've got some social things about him. He works as a contractor and lacks employer health and disability benefits. And guess what? That's a physically demanding job. He's not working anymore. So income, gone. Mr. Tarzia, except the Social Security disability. What's that? Normally 1,200 a month? That's what I've heard recently. It's a very difficult sum to live on. Very difficult sum to live on. And what you'll find with these individuals when this happens, that you start to see weight gain. Why do you see weight gain? Well, because they're making very difficult choices with their diet and what they're buying. He has a high school education and has struggled to retain new jobs. He has a housing risk voucher that he risks losing if he misses rent. And he's unable to attend social events that he used to attend. Social isolation. He's also unable to work and has dependents. Is dependent on his Social Security income. Next slide, please. So here's what I have for you guys, and Fide, I'll toss it to you. Mr. Tarzia makes a statement during his next PCP exam that makes you a mandated reporter. Quentin, why don't you speak up about that?
Just throwing a couple additional considerations for folks into the chat. So when we're thinking about social determinants of health, all of these things like work and isolation are extremely important. Some of the other things to keep in mind as well are other identities that these folks hold. Is Mr. Tarzia queer? Is he disabled in multiple ways? Is he Christian? Is he a religious minority? All of these different things have really significant impacts on their risks as well. And we know that a lot of minoritized populations also have extremely high levels of sexual violence.
Now, Quentin, can I ask you a follow-up about that?
Of course.
Um, so how is this integrated in your screening? Because when you last spoke, you mentioned you had a very comprehensive system. Are you asking about any of these as additional questions on SDOH screeners or through other instruments or other priorities?
So we ask demographic information when our patients first come in, and we update that at least annually every year. So that will give them the opportunity to tell us things like their religious system, their gender identity and their sexual orientation, their connectedness with their community, all of those different things. We don't necessarily require those answers, but we do give the opportunity for patients to share that type of identity information with us.
You know, I really do think I might be signing up to be a patient over there myself soon. So I love the system. And Fide, you know, when I think again about the migrants and I think about individuals that are first generation Americans and some of the experience my family has had, a health center that asks and cares about those things, when they ask about them, it does communicate that they care. And that does make people feel more welcome. I don't know what you think.
Yeah, no, I agree. I completely agree, especially when like even just like the simple fact of like how would they rather be seen like or communicate with a healthcare provider like in their own native language, like just that one single step that helps them, the patients, I think, feel more comfortable with sharing their information. And also I wanted to mention like back to what Quentin was mentioning. I was also looking at it like through like the social determinant of health perspective for this patient, you know, how to address all of those different things and assess all of those topics. So that was a really good input as well.
It's a perspective. The social determinants allows a new lens. You know, when I first started, and I'm not going to tell you how old I am, but I started medical school in 2012, and the social determinants of health was hippie stuff. I went to GW. This is a very left-leaning school, but it was still hippie stuff. It was kind of a thing on the side. As my career has advanced, STOH is now standard practice in the exam room. And that's a phenomenal change in a generation, and it's happening because people are making decisions on the management level and the program administration level. Because it doesn't matter if we want to do it in the exam room, if we don't have a framework, it's much more difficult. This empowers this in a way it empowers you to get the best out of your staff, and that's what I love about it. But thank you, Quentin, and thank you for the insight about that and expertise. Mr. Tarzia makes a statement during his next PCP exam that makes you, a mandated reporter, concerned that he may be experiencing violence at home. I left this broad on purpose. And I want you to answer one or two or both or with any combination. What I say is, when I say I value all the perspectives here, I don't just value them, I rely on them. So please use that chat box. It's there for you. What are your next steps, and what does your organization have to identify violence in patients like this guy who we see every day? And Fide, I'm going to go fill up my espresso and be right back.
Okay, sure, yeah. So we're going to give about 3 minutes for participants to provide your responses in the chat. You can also raise your hand and your line will be unmuted.
You know, Fide, as we're waiting for this, I'm just going to yap until you got something. So the best way to stop.
Sorry.
Sorry, okay, that was great what I just did. So I'm just going to start yapping, by the way. So the best way to stop me is to use the chat, folks. So I've been having a lot of conversations this week. Regardless of your political views, there's most certainly a transition going on. I have a weekly meeting with CDC and HUD, and I have spoken with Dr. Dante, the head of MHP Salud, and some individuals at the CHW coalition in Florida. If you're on the line, we'd love to hear from you as well. But what I'm seeing is a lot of anxiety about this transition from management down toward the whole spectrum of the workforce. People at the top are worried about funding, and they're worried it's going to change and what that's going to look like. And let me tell you, I'm in that chair right now, and it's just very scary one. It's a very scary one. But let me share some things that we're thinking about. And I will say broadly, all of the organizations that I serve with and what conversations are coming up. One, when you're dealing with rolling funding sources, having an extra $20,000 to $30,000 in an account that allows you each quarter to be able to wait for that funding and not go bankrupt is a lot of flexibility. A lot of people deal with that issue. Two, for those of you who are orienting towards funding, have a system that's looking at foundation grants, because that's where the growth is going to be in the next 4 years that we know we can predict that's going to be there. So those are conversations we're having. Is it time to interrupt me, Fide?
Yep. Yep, thank you so much, yeah, Dr. Lombardi. So we did receive a response by Rebecca Ibarra. And she said, "Good afternoon, everyone. Wendy, Ada, and I are all here from Heartland Rural Health Network. As community health workers, our first priority would be prioritizing needs, food and shelter, and finding resources to assist.
Get them on here. Come on, guys.
Yeah.
Come on, guys. And I will say that Wendy, I left you a voicemail today, and that we're gonna get on the phone and talk really specific about some CHW stuff soon. But we love CHWs here at NCHPH because they tell us how things really are. So, do you guys have opinions to share?
Okay, let me unmute the line for Rebecca. Hopefully you're able to chime in. If not, we understand.
We always are ready for communication, you know. We are always right here.
I'm sorry, Wendy. I'm sorry. I'm not great with emails. I apologize.
I am on disaster work this week, so I haven't been answering my phone, but let's get into this case. Ms. Rebecca.
Give it to me, Wendy. Come on.
Rebecca's taking the line.
Okay, good afternoon, everyone. So, you know, as community health workers, and we've kind of developed this system of filling the gaps, our priority when we get a new client, obviously we do an intake, we ask questions, and we don't have a specific, well, we do have a specific form, but we kind of go off the reservation quite a lot based on what our client is talking to us about. Where do we need to lead this conversation? And we partner, as we are not experts in anything, we're just experts in information and finding those resources.
And empathy.
I disagree.
We have a local organization that has a very specific program for domestic violence, sexual abuse, human trafficking. And so as we get referrals, we get someone that we feel that needs to have that conversation, we meet up with them and we have that conversation. And sometimes it's vice versa. They will have someone that the sheriff's department or the police department will refer to them, and they will actually meet them in hospital before they even walk out the door. And then again, we get together. They have their expertise, we have ours. Our job is to improve their quality of life
Through collaboration.
through collaboration, and, you know, try to get them healthy, happy, and safe.
Okay, so here's I've got a follow-up for you, because this is where people like me get confused. So when I see CHWs, I see infrastructure, and I see you in there linking this individual for everything they need. But it seems like an all hands on deck situation where this happens. So how do you manage it?
With less sleeping.
I'm gonna need something else. Okay.
No. Well, honestly, it's
Well, that's the TTA message of today, folks. Go home and throw your alarm clock out.
Right. No. Oftentimes, there are CHWs out here that have a very specific gap to fill. In our case, we're in a rural community. We're filling it all. Like Wendy said, this week alone, we are out in the community helping people fill out forms for their disaster relief SNAP food supplements. So we just fill the gaps where we need them. But there are CHWs with a very specific purpose. And what we do is we just come case by case. Our clients don't need us all of our clients don't need us all the time, but then there are clients that need us, you know, for a very specific amount of time, and they're very hands-on, and we may see them every day for 2 weeks, or 3 weeks, or we may see him once a month, or I have one that checks in with me once a year. I've tried to close this case, but he don't want me to close it because he wants to check in with me once a year. It's just, we do what needs must, and we do the resources, and resources change so often. It's a constant research, constant looking.
You know, I got to tell you, Rebecca, I've seen you and Wendy in action, and I'm going to call you out on something in a second. But I'm also going to say, listen, we get you guys talking because I want people to hear how CHWs talk about this, because these are the people that are working with us. And what you need to know is CHWs are community experts. And they do things like what I'm about to pick on Rebecca about. In past webinars, when you've spoke about, you and Wendy have very different professional focuses and skills. So in some ways, you've specialized in your collaboration with each other. Now, I've heard that, and I know it saves you time, but I'd like you to tell our audience, because I think it gives a good model of partnership.
Okay, so Wendy and I, we've developed this partnership, and we've worked together for years in different jobs, and it's her fault I'm working at this job. We can squarely blame it on her, but we have a different type of expertise through, I guess, just life. She's very business minded, and she is very great at filling out disability forms and all those kinds of things and reading the fine print. Whereas mine kind of goes towards, and she deals a lot with maybe our elderly population, our homeless population, where I have kind of just by accident or just needs developed my clients tend to be more migrant. Obviously, I speak Spanish, so that tends to fall on me. But I've also kind of landed in the pediatric realm where I get a lot of children that are referred to me. And oftentimes I find that those children have a parent that may have an educational need, maybe low literacy rate, low computer literacy rate, and a struggle with finding those specialists or coordinating care. And so both Wendy and I do coordinate care, but it just we've kind of split that way. So then when we have a client who kind of fits all of the boxes for both of us, we coordinate care with each other, and we've managed to kind of help our community that way. And where Wendy is very business oriented, I tend to be more research oriented and can go through and look for the information that we both need. And it just works out best that way. And I see other teams of CHWs that kind of fill in that gap as well, where one will learn something or do something specific so that someone else can work on something else, and just kind of no need to reinvent the wheel.
I love that. And you know, you guys are a perfect example of what CHWs do naturally. These are community-focused people, and they are natural communicators, and they naturally head towards partnership. Everything they do is partnership. Heck, the community, the patient care is partnership. It's coaching, it's partnership. So that's a level of expertise that we need, and by I mean people like me, need to hear. Have systems for your CHWs to send notes, to communicate with your CHWs. You have them, you hire them, get them talking, because they'll help each other. And let's be honest, when our staff works better together, they're happier, you save money, patients have better outcome, we all have a party. So, so I'll thank you, Rebecca and Wendy. I'll thank Quentin as well for sharing so much. And what I'll say is, we do this TTA in a certain way here. I am obsessed with FQHCs, PHPCs, health centers, everything you guys do. Health centers are the vanguard of health in this country, and you deserve the respect. You deserve respect because of that. we are going to be trying to form as much of a community during our discussions. And you can expect this format for everything that has my name on it and Fide's name on it going forward. And thank you for your communities. Thank you.
Mhm. Thank you so much. And I just want to apologize if we didn't get to your responses. We did receive a lot more responses in the chat, but thank you so much for your engagements. And then before we finish the webinar, I know we're right at the hour. Please complete our post-evaluation survey and let us know your feedback, anything that you guys would like for us to improve on, or any topics that you guys are also interested in us hosting more webinars on, especially on addressing the issues affecting patients with disabilities.
She really drills me on these things, folks. So if you have some ideas, they're gonna have.
Yes, we are just always excited. And if you guys let us know, like, okay, we want to learn more about
feedback,
this.
and
Yeah, we will make sure. We'll make sure to include that in our TTA. So here is also our contact information if you have any follow-up questions. And then please be on the lookout for the slides and the recording link.
Hold on 1 second. It's Kevin.Lombardi. Fide, that's why no one's emailing me. It's okay.
Kevin, okay. I will make sure.
I just wanted to embarrass you a little bit in public about it. But folks, if you need anything, call me. I like talking about this stuff. I'm speaking to people all the time. My secret meeting time is between 8 and 9 and 5 and 6 every day. Shoot me a call if you need to talk about things, or you're just excited about public health. I always have a cup of espresso here. You're going to need to take care of it over there. And thank you for your service. We love you guys over at NCHPH. And regardless of political orientation, I can say I'm glad I'm on the team with health centers. Ask yourself too, because I think everyone here is.
Thank you so much. Have a great day.